Well, I had not anticipated giving this talk today, but I'm happy to. This year for Grand Rounds at Johns Hopkins, I talked about this subject because there were just too many people saying, what's with the news we cover? What is going on with this? And these were the questions I was getting from my friends and my family. They're saying, we're not really sure about how effective these antidepressants are. You're going into these schools, you're talking about the importance of treatment, and yet it doesn't seem that there's very compelling data that it's actually even that helpful. And the thing that you have to talk about is really the placebo response. And I'm going to address that in a couple different ways, so I hope by the end of the talk you're able to say, right, when the critics of antidepressant treatment say this, they're failing to recognize that, okay? And I will also be honest about the fact that the antidepressant treatments we have right now are not perfect. They take way too long to work, and we are way too unskilled in choosing the right one for the right person to start. So those are the real limitations that we're all dealing with right now. So let me start with just a couple definitions. Efficacy, which you hear about all the time, is really saying, does the medicine work if we're under perfect conditions? So that's a randomized controlled trial where you say, we're going to pick people that only have this illness. They don't also have substance abuse, they don't also have anxiety, they don't have any of the things that everyone has, of course, that has depression or bipolar disorder. And we're going to do it in this very perfect way where we're checking on them constantly for about 16 weeks, and we'll see how it goes. And when you do these treatment studies, we start with the efficacy studies, the randomized control trials, to see if we maximize the conditions, does it work? And then if those are successful, you hope things would move on to what we call effectiveness trials. Now in psychiatry, we've really had one of those for depression, the STAR-D trial, where you go into more real-life situations. And we've had people present on that trial here where they actually said, we're going to real community clinics, and you can have comorbid substance abuse or anxiety disorders or more complex forms of the illness, and we will systematically try one thing, and if that doesn't work, we'll try another, etc. And so we have one trial where they did that. And we don't yet have what we call efficiency trials, where you say, we're going to do the real cost benefit, because there is a cost of the medicine from the actual cost, which is sometimes prohibitive, and what are the side effect costs, and what does it cost to actually admit to people you're taking it, balancing all that against the benefit. So we haven't done that yet. So most of what we know about these antidepressants are really coming out of these randomized controlled trials where you're saying, we're going to try to maximize optimal situations. And in the last year, there were two big studies, I'm going to review both of them, that got a lot of press, in which they more or less said these antidepressants don't really work. One was an article that was in the Journal of the American Medical Association, one of the most quoted journals in the world, where they took 6 studies where they had over 700 patients, and they compared those getting the antidepressant to those getting placebo. And they pulled together data from a bunch of these different studies, and they were comparing whether they got better based on whether their rating on the Hamilton Depression Rating Scale, so a very standardized measure where you ask about symptoms and come up with a rating of is it mild, moderate, severe. And then they compared that based on how bad the depression was when someone went into the trial. And this is what they found. Down at the lower levels, so down here you have the lower levels. I was told to use the pointer, so I'm going to try to do that here so it shows up in the video. At the lower levels of depression, the difference between what someone has when they actually are taking the medicine, that's the dark line, compared to the dotted line, which is placebo. Down here, there's not much difference. So that's the whole placebo and antidepressants are about the same. What's the big deal about antidepressants? And then when you get to more severe depression, so a Hamilton scale of 25, it's at severe depression you see this big difference. The difference can easily be seen between those taking the medicine and those on placebo. So this led to people saying we're not sure about that. And then there was a second meta-analysis done by Dr. Kirsch, who I have a bias, I think he had a bias. He wanted to show that these antidepressants were being given too much credit, so to speak. So he took all the information that had been turned into the FDA for Prozac, Cerazone, Paxil, and Effexor when they got approved. So that was more than 35, there was 35 studies. About 3,000 of the patients had taken medicine, about 2,000 patients had gotten placebo. And in general, they did find that the medicine group had a bigger change on the Hamilton compared to the placebo. And when he plotted it in a similar way, they found that both the placebo, that's the dotted line, and the drug groups improved, but at the low severity that there wasn't much difference, and you had to go out to more severe forms of depression to see a big difference between the medicine and the placebo. So all of this leading to this idea that there isn't really a big difference, and he actually made, I think, a rather concerning conclusion that there was little evidence to support the prescription of antidepressant medication to any but the most severely depressed patients. Now, I found this incredibly concerning, and that's what I had been quoted to me by family members and patients and my own family saying, I thought you were enthusiastic about these medicines. My father, the engineer, had some questions about all of this, and I said, okay, step one, it's not that the medicine didn't work. It's that the placebo worked really well. Step two, when it got severe, it was very clear that the medicine worked well. And when I gave this grand rounds, actually Dr. DiPaolo made the point that the initial studies of very ill patients in the hospital showed a dramatic difference. So everyone was agreeing that for severe depression, the medicines were effective, and it was at this lower level. And so I started saying, the implication that placebo is nothing is the problem. So let's take a step back of what actually helps mild to moderate depression, and that took me to Jerome Frank's Persuasion and Healing. Oh, I'm sorry, this is what got me riled up on the newsstand. I said, I am doing grand rounds about this subject because it's making me mad. So this is what was out there in February 2010. So Dr. Frank, in his seminal work, Persuasion and Healing, which he revised with his daughter, Dr. Frank, talked about what is psychotherapy at the heart. And he said it's the combination of three things: a healing agent, a person that wants to help, a sufferer who is trying to get relief, and then a relationship between those two. And what is the healing relationship? He was talking about a few things that were critical, that there was a structured series of contacts between the healer and the sufferer, and often, sometimes with a group, you're trying to bring relief of symptoms, that there are changes in emotional state, attitudes, and behavior. And although physical and chemical adjuncts may be used, the healing influence is exercised primarily by words, acts, and rituals in which the sufferer, healer, and sometimes a group participate jointly. I think this is one of the most beautiful descriptions about what we all try to do in psychotherapy there is. So you are together working on a problem, and it's a joint process. And then Dr. Frank had some very thoughtful things to say about the placebo. You know, what is the placebo? And he put it very, very straightforwardly. A placebo is itself a form of psychotherapy. Because the implication that the pill is therapeutic, of course, it's a sugar pill. It's not having any active ingredient, but it is a symbolic message. And I'm going to try to make the argument for you. One, that we know that psychotherapy is very effective for mild to moderate depression, maybe best effective in combination with medicine, but that it is effective for especially mild depression, and that the idea that you're in a randomized controlled trial taking a placebo is that you're getting no treatment is absurd, that you're actually getting supportive psychotherapy. So let me go back to the psychotherapy literature. There are many, many studies that show that psychotherapy is effective for mild depression, that the combination of psychotherapy and medication are most effective, especially for severe depression. So I just wanted to share a few highlights. This is from a meta-analysis, again, where they took a number of studies and combined them, where they compared some patients getting psychotherapy alone to others getting the combination of psychotherapy and medication. And the therapies, because they were studies, they tend to be these manualized therapies, so it was either cognitive behavioral therapy or interpersonal therapy. So where there's a clear-cut goal for each of the sessions, and they're being done as part of the trial. And the medicines were tricyclics, so either nortriptyline or imipramine. And again, they had a marker of how severe the depression was at the beginning, so they could divide into less severe and more severe depression. And what they found, not surprisingly, was for the less severe depressions that the combination therapy was best, but that the psychotherapy alone was quite effective for more than 40% of the patients. Something we know, that psychotherapy alone can be effective, and that for severe depression, there was a much more dramatic difference, where it was less than 20% where psychotherapy alone could help severe depression, and it was more than 60% that were being helped by the combination. And so that, you say that was in a group of people that were doing that combination, and then the NIMH was doing a longitudinal study of outpatients and did this very beautifully designed study where they had a randomized trial, and you were assigned to one of 4 groups. One was that you got interpersonal therapy alone. One was that you got cognitive behavioral therapy alone. The other was that you got imipramine, so an active tricyclic with careful blood level monitoring so you know you got a good dose, plus clinical management, or you got a placebo pill, so a non-active pill plus clinical management. And I'm going to share with you their description of what clinical management is to make the argument again that that really was supportive psychotherapy. And they had 250 patients, and you had to have fairly severe depression to get into the study, meaning your Hamilton scale had to be at least 14, and if your scale was above 20, you were in the severe depression group. So again, they could stratify later, comparing the less severely depressed to the more severely depressed, to see if there were differences. So in the first, they were comparing change in Hamilton. Oh, I'm sorry, here's the Placebo-Clinical Management description. Minimal supportive therapy, guidelines for management of medication and side effects, because you didn't know you were on the placebo, so they were talking with you about, this is how we're going to treat your depression, these are the medications. You would go over how the person was doing, getting details about how their time had been since you'd seen them last. You would provide support, encouragement, and advice about how to manage issues. But you wouldn't do specific things like a cognitive behavioral exercise. You wouldn't give homework. But these 4 first bullets sound a lot like supportive psychotherapy to me, where you're actually talking to someone about what's going on, trying to help them problem solve, and supporting them, saying, you know, I think we're doing something together that can help you to feel better. So what they found was that for the, again, the less severe, so that's this group, all the different medicines, placebo, et cetera, were all about the same, in that everyone got better. Remember, everyone had to be above 14 to start, so everyone had an improvement, and their Hamilton improved significantly, but you can't really tell the difference between placebo and CBT and imipramine. But if you got to the more severe, the placebo group did not improve, because a higher score is worse, and the imipramine group improved the most. I want to make a point about this whole Hamilton scale as the way to measure. It's a very standardized way to do it. It gets done all the time, but it doesn't really capture functioning. And it doesn't capture whether someone's gotten better or recovered, and that will come up later as we're revisiting those first studies. So the other measure they used in this study, I think is very important, was the Global Assessment Scale, the GAS, where they looked at how the person was doing in their functioning roles. And there you see an even broader and more dramatic difference, where again, for the less severe depression, everyone's all clumped together. They're about the same, whether it's interpersonal therapy, CBT, the placebo, or imipramine. So there isn't really any difference, but if you go to the more severe, the difference between imipramine or taking medicine plus supportive psychotherapy versus placebo is really dramatic. So all of that is supportive of what we already knew. Psychotherapy works for depression. Combination of psychotherapy and medication is better. But where are we in 2011? We still have difficulties. We don't have an antidepressant that's better. You know, it's not like the antibiotics where you know you're going on something that has some Axin in it and you know it's going to be fabulous because it's going to kill everything. We don't have something like that. We don't even really have direction. If an SSRI doesn't work, what should I do next? I mean, that is all very individualized and we have to take guesses. And unfortunately, in at least the studies, you usually only have psychotherapy in these manualized sort of forms. Not that those aren't excellent kinds of therapy, but that might not be the best match for someone. I think most of us realize that you have to match the therapy for the person you're working with. And importantly, it doesn't get to any of the things that Dr. Treisman talked about earlier. If someone is continuing to drink alcohol, continuing to smoke marijuana, continuing to cut or other destructive behaviors, they're not getting addressed, and individuals that are open about doing those things aren't even being included. And we don't really have long-term follow-up. So these are all of our options. We have lots of options, but none of them is better than any other. Now, for an individual person, almost always one of them is dramatically better than all the others. It's just that no one can tell you on the front end. I mean, that will be very exciting, and many people, Dr. DiPaolo has said, that might be one of the first things we get from genetics, being able to understand this is a family or group of individuals more likely to respond to a tricyclic or an SSRI, but we're a ways from that happening. So what we have now are theories. This is a beautiful picture from the New England Journal in which someone is describing what we know to be the first step, that you have serotonin, you block its uptake, so an SSRI, selective serotonin reuptake inhibition, you block its reuptake, it builds up, it binds to these other receptors, and then things happen. This is my favorite New Yorker cartoon, which is, I think, where we are. That it's then a miracle occurs. If it were as easy as there's a serotonin deficit, it should not take 4 to 6 weeks for these medicines to work. Anyone who's had someone they love waiting for antidepressants to work, you know how incredibly frustrating it is. So there is no doubt that there's actually a cascade. We know about the first step. So we talk about SSRIs and SNRIs because we know the first steps of what they're doing in the brain, but there are probably multiple steps. They probably turn on certain genes and turn off other genes. We just honestly don't know. What we're good about is recognizing the illnesses and knowing the options, and then we try to be systematic in how we do it. But what are other factors that have nothing to do with the limitations of the medicine that contribute to the fact that it is reasonable to say, I'm not so impressed with antidepressants? First is that we're not always good at getting the right diagnosis. Dr. Joshi alluded to that earlier, and I completely agree with her, bipolar disorder in children, it's underdiagnosed, it's overdiagnosed, and it's misdiagnosed. And that's the same with depression. We aren't recognizing the other conditions. If you're drinking, I have lots of teenagers I work with that think that marijuana 3 times a day is an outstanding supplemental treatment for their antidepressants. We have very frank discussions about the fact that there is no way anything we try will work if that is continuing, but they are enthusiastic. This is where you have to really educate someone and win their cooperation to see that my goal is their health, not trying to be the police or tell them anything else. So that's a problem. There are huge problems, especially in primary care settings where someone does not get an adequate dosage of the medicine, but that's also been shown to be very problematic in specialty psychiatry clinics. So people don't get up to a high enough dose either because they're not taking it, or the side effects are terrible, or we are failing to advance the dose properly. And then we either keep someone on the medicine for too short a time. Well, in 2 weeks it's not working, let's try something else, even though that's ridiculous for the timing, or too long, where you're on an antidepressant, so we'll just keep that for a couple years and see if it does any better the 2nd or 3rd year. So these are all problems we have. But just getting back to the idea of diagnosis, so if you look at the differential diagnosis of depressed mood, many of these conditions are not well treated with antidepressants, but we're really trying to. If you go to your primary care doctor and are tearful in the office, there's a very high % chance, based on recent studies, that you'll be given an SSRI. It could be that you're grieving. It could be that you have just gotten very bad health news. It could be that you're demoralized about a situation in your life. Antidepressants will not address those, and hopefully someone would get the psychotherapy they need to address those, but they won't if they think they're fixing it with this medication. Major depression and anxiety disorders are absolute reasons to prescribe an antidepressant, but with bipolar disorder, if it's not recognized, we're going to hear later about the fact that antidepressants sometimes are a part of the problem. Can contribute to cycling or moods becoming more destabilized. As I already alluded to, there may be other issues going on that simply aren't addressed, and it's unrealistic to think that an antidepressant is going to change someone's pattern of drinking or whether they're using drugs. Now, that doesn't mean that not treating the depression isn't critical. I don't think it's fair to ask someone to work on getting sober if you're ignoring their mood disorder, because they're not going to be successful. So that's a different issue. But then there's also whether we're good at what we do. And I think we're good at what we do frequently, and that's what this study, where colleagues at Vanderbilt and the University of Pennsylvania collaborated, really shows. So what they said is, we're going to build on the work that was done at the NIMH, and we're going to do a 16-week trial. and we'll compare antidepressants, which someone was taking either Paxil or Paroxetine, and then if that alone didn't work, the physicians had the option of adding either lithium or tricyclic antidepressant, or you could be randomized to go into the cognitive behavioral group, or you could be randomized into a placebo group. And then after 8 weeks, you had the option of going into one of the other 2 treatment arms. So here's this very interesting study where they're going to say we're going to take state-of-the-art psychotherapy and compare it to state-of-the-art medication. And it was done at the University of Pennsylvania. Any of you that have heard the name Aaron Beck knows that the birthplace of cognitive behavioral therapy is the University of Pennsylvania, and also at Vanderbilt. Now, at 8 weeks, they had done that mini study to show that compared to placebo, both antidepressant medicine and cognitive behavioral therapy were superior. So getting to whether these are both effective treatments, that was very positive data. But then what they found, fascinatingly, was that where you were in the study had to do with which treatment worked better. Okay? Probably will be not a surprise to anyone that at the birthplace of cognitive behavioral therapy that they had a better response rate with cognitive behavioral therapy. And they had more experienced therapists with many more years of doing CBT, and they were very highly skilled. Not that the people at Vanderbilt weren't skilled, but there's experience is experience. Now, it might be interesting to know that at Vanderbilt, on average, people are on 10 milligrams a day higher dose of Paxil than they were at Penn. And they were much more likely to have either lithium or tricyclic added. So they got much more aggressive antidepressant treatment, and one might argue more state-of-the-art antidepressant treatment at Vanderbilt. So to me, this is pretty hopeful. You're at over 60% response with both if you actually get optimal treatment. And without it, you're at about 60. So I think this is a very interesting idea of the treatments work, and if you have someone skilled and experienced doing them, they work even better. And so that leads to what we do here at the Mood Disorder Center. We are all influenced by Dr. McHugh and Slavny, who wrote this wonderful book, The Perspectives of Psychiatry, and we really try to be comprehensive in taking care of the patients, hoping that we are going to include a combination of everything. So we recognize the diseases. We look hard to look for the mood disorders, depression, bipolar disorder, other diseases that are going on, and to get the diagnosis right. And we're working hard to try to figure out what's going on with them, but that's what we're doing for diseases. With dementia, that's really looking at who someone is, what's their personality, what's their style. No 2 people would present with depression the same way. A very quiet person might have it missed, where a very lively person might march into your office and say, I feel lousy, you got to fix this. Whereas you might miss the mania in a more lively, outgoing person. And then, as I've said multiple times already, when there are behavioral issues like substance abuse, cutting, eating disorders, other issues that are very serious, if you don't address those directly, then you're not going to be able to have success in treating the mood disorder. And then finally, I hope we never forget that all of these events and illnesses and challenges are happening to individual people who might feel differently about the illness because it does or doesn't run in their family, who might feel differently because it did or didn't happen when they were a sophomore at college. I mean, all of these illnesses happen to individuals, and if people don't have an opportunity to talk about what it means to them that they've taken on this illness and that they now have this challenge, then we're doing them a disservice. Plus, they're very unlikely to be open to our treatments. That's the bottom line, as Dr. Jameson was saying. So what is our perspective-based treatment? Well, first, it's that we want to do a careful evaluation and diagnosis, and then we want to be able to treat the mood symptoms as we need to with medication. For individual challenges in the way you interact with the world and maybe make things harder for yourself, that's a focus of psychotherapy. We obviously want to interrupt and take care of the kind of behavioral problems that people are having. And then obviously we want to have people to have a chance to talk about what does it mean that you now have a chronic and potentially recurrent, very serious illness. And that treatment means that you combine medication and psychotherapy and often family therapy and interrupting the behaviors, and essentially you take on doing what you need to do to help that person. But it always really needs to be a combination of medication and psychotherapy to be effective. And so I'm back to where we started. This study, in which Dr. Kirsch really raised the flag to say these antidepressants aren't really indicated. I hope I've been convincing to say it's not that drug does nothing. It's the placebo is also something in these randomized controlled trials. Psychotherapy is effective treatment for mild to moderate depression, and for severe depression, the medications, here we go, the medications are much more effective than psychotherapy alone, and we know that from other studies, that with those patients with the most severe forms of the illness, you really want to do everything you possibly can, and that's combining psychotherapy and the medication. Thankfully, it's not just us here disturbed by this, but it was also a group in Europe. And CHMP stands for the Committee for Medicinal Products for Human Use. Doesn't that sound very British? Medicinal products for human use. They reassessed Dr. Kirsch's work and said what we were all saying as well. It's a little bit of a problem that you're not looking at anything other than change in Hamilton, because it might be that someone has a small change but they've recovered because they weren't that ill to start. We don't think you should just view these as things that you can add up, and you're not looking at relapse versus response versus remission rate. So they had some concerns about the way he had evaluated this, with the concern that perhaps there was a conclusion they were trying to draw. And his group came up with the conclusion that the approval of antidepressants for the treatment of patients with major depression has been based on data that will provide robust and sufficient evidence of clinically meaningful benefits for patients with major depression. And I think that's what we know clinically. For some patients with mild depression, antidepressants are tremendously helpful. And for moderate and especially severe depression, they are critical. And so this idea of the Newsweek article, you will notice that they had the flip side on the article, but it is not how it was sitting, in the counter. The other side was what was up. So antidepressants do work, and I hope, because you are a special audience, you are a group of people who are advocates, and you are the ones willing to have the conversations at the dinner party about this, that you now can say, the problem with that whole business was that they weren't giving the placebo enough credit. It was really psychotherapy. And so in conclusion, our antidepressants, we know that they work, and most of what we know about their efficacy, how well they work, are from studies that are important but are not exactly real world. And we don't have the benefit of following people for long-term care so that we see what happens over time. And those are some of the things that we need to do in the future. We know very importantly that if you don't have someone on an antidepressant at a high enough dose for a long enough period of time, it really has very little chance of working. And so as supporters of those starting treatment, I think that's one of the most important things we can do, to remind them that you have to get up to a full dose and you have to give it some time before it's actually going to even have a chance to work. It's also impossible to think that you can treat major depression or bipolar disorder without looking in someone's life and seeing what else is going on, that they just have to be addressed together. Now, you might make an order. If someone is very, very ill, they may need to be in the hospital for a short time before you're working on other things, but you can't ignore them. And we don't want to reduce anyone to just being their illness. I mean, that's just a terrible thing to do. And that's why, we all here advocate for the combination therapies, that we have good data that they are the best combination. So with that, I thank you for your attention. Oh, great question. The difference between manic depression and bipolar is sensibility, in the sense of manic depression and bipolar disorder are exactly the same thing. It's just with the advent of some of the nomenclatures that they changed it. So we're all biased. We actually prefer manic depressive illness, but the official word is now bipolar, meaning two poles, your manic and depressive illness. So exactly the same thing. So the issue is the after effects of quickly getting off medicine. So there have been recent studies with ketamine that show for those with whom it worked, because there are a whole group of people where it doesn't work at all. That's what they're not emphasizing, that there's this really fast onset of benefit, but when you stop it, you can quickly crash into even a suicidal depression. This idea of abruptly stopping medications and having symptoms return is a real issue. And actually, most of the studies that address the issue of suicide will find that people actually don't have antidepressants in their system. It may be that they've stopped them, and that is a problem. It's a problem because some people will have withdrawal symptoms. So you might have withdrawal from the SSRIs or the others where you feel agitated or even sort of physically unwell. The other is that if it was doing good, you've now lost the benefit. So that is a problem. But with the antidepressants, It's almost more of a problem sometimes that you don't see the negative effects for months. So I have plenty of people that go off to college, decide that they're going to choose beer over Zoloft, and they say, you know what, it was okay a couple days later. I felt okay, because the negative effects don't come for a while. And so there are a lot of different reasons it's concerning. Obviously, no one would want someone stopping a medication without it being part of a plan, and the safest way to do that is to slowly taper off the dose, just so you can see the effects, or you're going to get depressed again, but also minimize any kind of negative effects. So the question is about studies that are trying to use things from blood tests, blood types, genetic markers to see if there's certain medicines that work more or less. My understanding is that that's very much at the research stage, but I think that's everyone's hope, that that might be one of the first benefits of genetics, that we'll be able to identify families more likely to, say, respond to lithium versus Depakote or certain antidepressants. So that is not certainly at a stage where we can use it to help an individual patient in someone's office. So hopefully ongoing work will lead that to be more helpful.
Yes, ma'am.
Right, so the question is about essentially the fact that our system is broken at this point, so that someone could actually be in the hospital for only 1 week, where they may have the opportunity to start a treatment but not have adequate follow-up or be able to maintain the medication. It is distressing to me, because obviously there is no antidepressant, no mood stabilizer, no treatment for anything within the realm of psychiatry where you're going to get a cure in a week. And so we have to put efforts into advocating, I think, for better resources for follow-up care, as well as better resources to support the coverage for the kind of medications our patients are taking as outpatients, because they're prohibitively expensive at times. No. So the reality is that none of us in this room probably would qualify for these studies, and I think that's a very important point, because for the randomized controlled trial, you really can have no comorbid condition. So you couldn't have an anxiety disorder, difficulty with substances, personality difficulties, and it means that it's a very funny group of people that we're basing most of our decisions on, and that we're basing a lot of the evidence on. Now, it doesn't mean that they're not responding to the medicine. It's great that they do. It's just that I think with the STAR-D and future studies, we have to have much more real-life examinations of how well these medicines work.
Let me stay with it for one more minute, and that is to say, among the things that rule you out of these studies, I thought, were being suicidal.
Oh, yes.
Being delusional, etc. Okay?
So you can't be that ill to be in the studies, is the point Dr. DePaula is making. And we are, I think it's our great commitment, and I just want to give a shout out to my colleagues from IR4 who are here, that I think that we are prepared to work with anyone, and I think we have great skill. I mean, I think our nurses are amazing, as are the social workers and OTs on our unit, that really can support people when they're at their worst. So.
Which means this funny group of people that doesn't have anything else wrong with them.
Well, it's large, because if you figure that, so the question is, how large is the perfect group in the randomized controlled trials? If 20% of women, by some estimates, have depression, that's a pretty big group to pick from, and 10% of men. So, you know, the studies have hundreds of people in them, not thousands, where we have millions with depression to choose from. So,
if I could, since I get to editorialize at will here sometimes, is that one of the reasons the drug companies have stopped using the severe patients, okay, because you can get the effect with a lot fewer patients if you use really severe patients, is that these patients really are severe, and they're giving a pretty, sometimes cursory treatment. That is, here's your pill, okay, and they were having patients do things like commit suicide. So what they found was they could produce a statistically significant result with milder and milder and milder patients. So by the way, so it's not only severity that will predict outcome, okay, with antidepressants. You could even do it because of this effect, this social effect, by when was the study done. So an old study is more likely to find a difference than the new studies are, okay? But they don't mind that, by the way, because P less than 0.05 is all the FDA cares about, okay? They're not looking at some of these other factors.
well, and they're not taking on the fact that these are potentially life-threatening illnesses. You know, they're, and that's okay. I mean, this is my self-disclosure. Merck stock options paid for my education. You know, my dad worked for Merck. He's a good man. It's not that they're doing something bad, but they're going to try to minimize their risk. I mean, that's what they're doing. That's not. Well, part of it is getting the questions about the issue of statistics and why do we pick something arbitrary like a 0.05 difference. I mean, the truth is that we're getting more sophisticated in that. And so what was viewed before as a standard statistically significant difference, now I think people are looking more carefully at what's a clinically significant difference. And I think that's been very helpful. If you get a large enough group, you can find a difference of any sort. Whereas what they're doing now is actually incorporating that and looking at other new statistics like effect size that take into account, yes, you got this big a difference, but you had this many people. That's not that impressive. So I actually think we're doing a better job of that now. So the question is, in these kinds of studies, are they looking at other things? They're not. And actually, because of limited time, and one of my favorite slides to show are all the non-pharmacologic things one would hope anyone with a mood disorder would do, which starts with sleep. How many people got 8 hours of sleep last night in this audience? My hand is not up. That is a healthy thing to do. So you worry about sleep and exercise and eating right and all of those things that are really critically important as well. Sure, so the question is about how could we as a group of practitioners who are maybe not, at a big academic center where you tend to do things that, you might be doing the study, how do you advocate? Well, I think it's what Dr. Jameson alluded to. I think we have to do it at the most basic level, and I think we need to be probably writing to our members of Congress and Senate and other places saying this is not reasonable, because they're practical things. We all have to pay the mortgage too, and so we can say, oh, don't worry about what you're being reimbursed for, spend extra time. Well, that's not always practical. So I do think that we can do it, and I think we need to do it, push our professional organizations to do it. I mean, I'm personally, that's not what my skill is, but I am very supportive of my professional organizations that have people doing it. So I think that's another way to do it, to make it on their agenda and also support their efforts. Okay.